We are moving on to our next presenter, Mr. Emmanuel, asking to present on the topic of extent of integration of social determinants of health in clinical practice in hospitals in Uganda.
Evening, good afternoon, and good morning, our dear listeners. My name is Emmanuel Higenyi, and I'm a PhD candidate at the Texila American University. And the topic I'm interrogating for my graduation is integration of social determinants of health in clinical practice. And the topic will be coming in three also phases. The first one is extent of integration of social determinants of health. We know that in many medical conditions that health workers manage in the health facilities, they have their origins in the social determinants of health, which actually influence and mediate a number of aspects related to health of individuals and diseases. And moreover, these determinants also influence the way people perceive and explain illness. And certain patients will be exhibiting certain social factors and require adjustment of care and treatment approaches. So, and all this will have implications for outcomes of treatment, prognosis, and patient safety. Therefore, health workers need to pay attention to these social factors and provide care and treatment that is complete, holistic, sensitive to culture, context, and patient preferences, which means then it will be valuable to patients and society. As we know, this area of integration of social determinants of health is an emerging area when it comes to integrating those social determinants into clinical practice. Although social determinants have been talked about widely in the areas of general macroeconomics and so on, but integration in clinical practice is an emerging area. And it's important to know the extent to which health workers integrate the determinants into clinical practice so that we can come up with measures to improve the integration. In this diagram, I attempt to illustrate how the different determinants impact on the healthcare continuum. And we see there are two sides. There are areas where the determinants affect the interaction between the patients and the healthcare workers and the health system. And then to the right side is the interaction between the social determinants and the general well-being of individuals. So integration in clinical practice begins with the side of clinical interventions where these determinants can impact. So I am explaining this diagram, which shows the various mechanisms through which the social determinants of health interact with the influence health and healthcare outcomes. So to the left of the screen, we see that there are areas, there are issues, there are aspects where the social determinants influence how patients interact with health workers. And to the right is how social determinants influence with the impact on the general well-being of individuals. So this is just a highlight to show the importance of actually considering these social factors in clinical practice. Now, the role of healthcare workers, there are different opportunities where healthcare workers can actually make impact on social determinants, especially by focusing on looking at how they can identify patients who are affected by these social risk factors and attending to them. And a number of activities and actions related to the extent of integration of social determinants in clinical practice have been described in literature. And so by identifying those and addressing those social risk factors during patient care, the healthcare practitioners can provide accommodative, focused, sensitive, informed care and support patients to cope with or manage their social challenges, and as well as engage in collaborative advocacy. So this is basically in line with the social accountability paradigm, which is properly described. And the issue here is that health workers need to start getting interested in how to practice the social accountability framework in healthcare practice. So hospitals and healthcare workers can successfully, consistently, and effectively connect patients who have social needs to available social services in the community. Now, in literature, we know that the extent to which these determinants are integrated has been mainly covered in Western countries, most especially the United States of America and a few other European countries. And scholars like Andaman have investigated this subject and have given advice. And also, according to Gag et al., who observed that in 50 to 60% of patient encounters, health workers did not take initiative to understand the social risk exposures. But also in over 90% of the cases, health workers did not even screen and address possible clinically relevant social factors. And similarly, the medical group management association survey on screening for social determinants indicated that screening of patients for social factors generally was low and was at 52%. And this data has been validated and attested to by other authors. Now, we know there are a lot of dissimilarities in the way the screening is done, and also that the instances where screening has been undertaken, there are no specific interventions that are followed up there are no specific interventions undertaken by the health workers to support the patients who could have those social risk factors. And when the interventions are reported, they are heterogeneous and also inconsistent, hence highlighting the big problem in this area that would require a proper investigation. And so it makes it difficult to really compare the different settings as far as integration is concerned. In Uganda, just like in many other countries where I live, the extent of integration of social determinants in clinical practice has neither been elucidated nor documented. Yet the knowledge and understanding is vital for enhancing the integration. One key challenge which is there is lack of a proper metric to use for measuring this integration. But we take lessons, I took lessons from the frameworks defined by Andaman and the other studies to come up with the definition and the measure, so that I solved the problem of lack of a standard definition and also the inconsistency that is arising because of lack of the definition. And therefore, the study has proposed a very clear definition and method of measurement. And the definition and measurement of extent of integration of social determinants of health into clinical practice is therefore a combination of three attributes: the degree to which health workers or hospitals identify and manage social risk factors during patient care, the extent to which hospitals and healthcare workers organize their services to manage in a manner that takes into consideration the social determinants of health, and the level at which hospitals and health workers engage with communities and social service providers to mitigate social risk factors. So those three attributes constitute the definition and therefore guide the measurement of extent of integration into clinical practice. And these are basically mainly from Andaman and the National Academies of Science, Engineering, and Medicine. So the objective of the study was therefore to investigate and determine the extent of integration of social determinants and how the extent varies across hospitals and the socio-economic and socio-demographic variables of the health workers. The research process, as properly detailed here, which I'll not go through the detail, but it went through proper conceptualization, operationalization, and then looking at developing the tools and so on until the reporting, which is currently going on. In the study was conducted in 2 government regional referral hospitals, 8 private not-for-profit hospitals, and 2 private hospitals. It was a cross-sectional hospital-based study. Sample was comprised of 1,042 health workers. medical records, actually medical records are 2119, not 600, and 6 focus groups and 21 key informants. Data was collected between September to November 2021, and data from health workers was collected using self-administered questionnaire. Data from the key informant was collected using key informant guide, and data from medical records was collected using medical record review template. And data from patients was collected using a focus group discussion guide. And the sample size was calculated based on the well-known formula for cross-sectional surveys. And it was adjusted for finite populations based on the means of health, known number of health workers at the time. And the key informants and medical records and focus group discussion sample sizes were based on literature. Health workers were sampled based on availability and willingness to participate in the survey, and only the health workers that had served at the point of employment for at least 3 months were included. And the key informants had to be heads of departments for a clinical department. And the medical records were those that spanned a period of 12 months from the time of the data collection. And for focus groups, the willingness for patients to participate was most important, but also they were ambulatory patients, that means outpatients. The tools basically, as I've already highlighted them, self-administered questionnaire, key informant guide, medical review template, and focus group discussion guide. So for extent of integration, I used the Likert scale approach based on the advantages, and I had 8 attributes which comprised the extent. So the extent of integration, I treated it as a latent variable that would be comprised of these 8 attributes that were presented to health workers in an ordinal format with 5 ratings. So the health workers were required to indicate the extent which they were involved in each of them. And these were validated using reliability analysis and Cronbach alpha, and they were found to be adequate. The same happened with the key informant guide. My key informant guide, which I am using for the entire study, it has 3 components. One was a quantitative component. The other is a semi-quantitative, and the other is basically qualitative. So for purposes of integration, I used the quantitative part of it. And again, I was using the Likert scale approach, validated using Cronbach alpha for reliability. To get to know how, to the extent which health workers documented the social factors in the medical records, I used the 4 medical conditions of high priority in Uganda: malaria, hypertension, diabetes mellitus, and tuberculosis. So for each of these conditions, I selected the specific factors based on literature, which are key to management and the transmission of these conditions. So I checked the extent to which these social risk factors were documented in the medical records. And then I computed that into percentage. The study was approved by the Research and Ethics Committee of the Makerere University School of Sciences. And of course, the National Council also approved it. And data was analyzed using SPSS. In terms of results, definitely my response recovery rate was 90% for health workers, and 98% for the rest of the 99% for the, I can't see my screen very well, but so basically my overall was good enough for the recovery, for the sample recovery as per the plan. And the sample characteristics was that the mean age of the respondents was 28, and the majority of the health workers were Christian, and the mean period of active service was 5 years, and the nursing and midwifery was the predominant profession. And 64% of the health workers reported that they had encountered the social determinant in their practice 3 months preceding the data collection date. And the method they used to uncover these social determinants was mainly taking history. And some of them examined the clinical notes of their colleagues to uncover the social determinants. And a number of the social determinants encountered are highlighted here. They include financial resources, health literacy, etc., as per the table that is highlighted there. Now, in terms of extent, the overall extent was computed from the health worker data, key informant data, and the medical records, and was computed as 66%. Interestingly, the one for health workers was 66, medical records was 66, and key informant was 65. So I computed them through arithmetic average. For documentation, as I said, it was 66 on overall, but hypertension was performed better in terms of documentation. And there are specific social risk factors that were saliently missing that are highlighted there. For example, alcohol abuse, education, and the income instability in diabetes mellitus, which are key. Tobacco use in TB and diabetes are very key and they need to be documented. So how did these vary across the health facilities? So this chart here shows how the extent of integration varied across the facilities. We see that the lowest was about 50, the highest was about 76. And again, I also present variation across each of the items per hospital. And I also present variation across the medical conditions by hospital. And then I also present variation by social demographics. And I see age, gender, religion all being significantly related to a number of the factors, but also to the summated variable for the extent of integration. What I have noted here is that profession and the professional body, they behave similarly, because the professional body most of the time is closer to what the profession is in most cases. Now, also continuing, we see that qualification also had a very significant relationship. And here we saw very clear underpinnings, bringing out who is likely to be, which profession and qualification was more significantly related. And we are seeing that the nurses and midwives are more likely to document in the records, whereas the medicines and the dental practitioners are least likely. But we also saw that for the PhDs and the masters are more likely to document. Now, in terms of discussion, the sample size and response rate was affected by the COVID-19 pandemic control guidelines, because hospitals were not working full capacity. So it constrained a little bit, it made the study a bit tighter to manage, but all the same, at least I got a very good recovery rate. And the composition of the sample for the health workers in terms of age, gender, religion is very close to the demographic profile for the general population and also for the working population in healthcare. And of course, the extent of integration, which I uncovered in my sample, is higher than what was seen in the literature. And this could be because in literature, they were using mainly the lower level of assessment, which means micro level interaction with the patient, but not talking about community and beyond. And the low documentation definitely becomes an issue, especially in issues related to health literacy, education, occupation, which are very key in disease management, but also for public health. And the difference in extent of integration across the hospitals is also of key concern, because we expect that these hospitals operate under the same policy umbrella and using the same guidelines. So in conclusion, the study has achieved the objective of determining the extent, but also brings on board a very key method for measuring the extent, and therefore validated it, and they proved that using that approach, we can come up with a good measure of the extent for integration of social determinants of health. And because we saw that the methods had similar results and they are close to each other. So, and using reliability analysis, they were also found to be quite reliable. So I think that then this could be adopted. The potential study limitation was social desirability bias, because mainly the health workers were providing self-reported information, but because of the multi-method approach, the impact was made benign. And therefore, it is not a big concern here. The main issue which comes up is now the number of hospitals that may affect external validity. However, looking at the demographic profile of the health workers and mapping them on the demographic profile of the population, of the entire population, we see that they are very close. So there is a tendency to believe that it could still be externally valid. Based on that, we recommend that the method of measuring the extent of integration be adopted, and using the 8 Likert scale items, which were found to be very reliable, coupled with the 24 Likert scale for the key informant guide, and also supported by the medical review template, and validated or counter-validated using the focus group discussions by patients. Some of my references are here, and there are many, but allow me just to show only these ones that have enabled me to consult the literature and come up with the methodology, come up with the discussion, but also make the measures very specific and conduct the analysis. I thank you, and I entertain some questions as they may arise. Thank you.
Thank you so much, Mr. Emmanuel, on the topic presented in the theme of academic research. Dear participants, please vote for Mr. Emmanuel for the presentation done on the topic of extent of integration of social determinants of health in clinical practice in hospital in Uganda. Please raise questions in the chat box so that we can ask those to answer by Mr. Emmanuel. And we reached the first question. How did you get the convex alpha for test of reliability?
Okay, thank you. So I used the SPSS version 26 and analyze, then go to reliability, and then enter the attributes into the dialog boxes and run the test. That's how I got the Cronbach alpha. And it then brought the alpha, the inter-item correlation, etc. And all of them proved that the measures were very reliable. They were measuring one construct, and there was no noise in them. Thank you.
Thank you so much, Mr. Emmanuel. Okay, you have another question. What is the model that you designed out of this study for adoption?
Oh, okay. So thank you for that question. That is actually part 2 of my study, and the analysis is already going on. It's basically based on ordinal regression. It will be an ordinal regression model, and it will have predictors, and the predictors then will inform how interventions can be managed. Thank you.
Thank you so much, Mr. Emmanuel.